Folks, we're going to get started in just a moment. Welcome to the Fireside Chat series at 6 Degrees Health. We're really glad you're here. We'll do some introductions in a moment. Hi, Jasmine. Do this once a month. We've been doing it since 2020. It's always great to see some of these familiar, well, the faces, certainly Heath Potter, but hi, Ryan. People are saying hello. I love it. This is absolutely perfect. Okay, it is 11:02, and I believe it's a good time to get started. My name is Gray Campbell. I am the 6 Degrees Health Learning and Development Specialist. 6 Degrees Health is a company based out of Oregon. We do cost containment for self-funded health plans, everything from reference-based pricing to cost containment solutions, payment integrity, transplant, specialty network, out of network, solutions such as that. We right now have a couple of guests, Dr. Ronald Potts, who works for 6 Degrees Health, and Mark Trusheim, who is joining us on a fantastic, very exciting upcoming topic, which is near and dear to a lot of folks here at 6 Degrees Health: precision reimbursement approaches for managing those high-cost therapies. So what are high-cost therapies? We'll get into it, but I do want to go over our agenda today. Precision reimbursement approaches for those high-cost therapies with Dr. Potts and Mark Trusheim. Mark works for NEWDIGS Innovations, and he'll be talking specifically about these durable therapy financial challenges and solutions. And also how, and this is the important part, how do we pay for these cures? And we really want to talk specifically about the pricing on this and how we are setting ourselves up to pay for these, what are very expensive cures. And we'll get to why those are expensive in a moment. Really important, everybody. If you have any questions, please use the Q&A function. I see people in the chat right now saying hello, and I really appreciate that. But we have the Q&A function if you have questions for Mark or for Dr. Potts. Heath Potter will be managing that in the second half of today's webinar. So let's take a look here. We've got two folks I want to talk about. I think we're starting here with Dr. Potts. Dr. Potts has been the Chief Medical Officer at 6 Degrees Health for, I don't know, about a year now, Dr. Potts?
Yep, that's right.
That's about right. And Dr. Potts, great resume, certainly working for Kaiser Permanente for 13 years. And he's also worked in the solid organ, blood, and marrow transplant for Kaiser nationally. He left his role as a Chief Medical Officer at Interlink recently, and he spent 15 years, don't know if that was recently, I apologize, developing innovative programs with the solid organ and stem cell transplantation for the Transplant Network organization, as well as Interlink's Cancer Care Initiative. He's a graduate of Stanford University and the University of Cincinnati School of Medicine. Welcome, Dr. Potts.
Thank you, Gray. And actually, I've been with Kaiser for 50 years.
Okay, I apologize. Wow, that's super impressive. I'm really, really glad. Jackie says, love you, Dr. Potts. We all do.
Hi, Jackie.
Thank you, Dr. Potts. I do want to introduce Mark Trusheim. Mark is joining us. I actually listened to some of Mark's webinars on YouTube. Mark, intelligence is right there in your back pocket. I really appreciate all the words that you have to say about what's going on at NEWDIGS at Tufts University, Tufts Medical Center, where you co-lead and the financing and reimbursement of cures in the U.S. Focus project. Okay, so reimbursement, that's why we're all here, certainly since 6 Degrees Health works in the reimbursement world. You're the president of the CoBio Consulting LLC, and you're have been the visiting scientist at MIT Sloan School of Management. Through MIT, you've also served as a special government employee for the FDA's Office of the Commissioner. Mark's research focuses on the economics of biomedical innovation, especially precision financing. We're going to get into this precision financing here in a minute. For patient access, precision medicine, adaptive pathways, platform trials, biosimilars, and digital health advances. His career has spanned big data at Canon Systems, marketing at Siri Pharmaceuticals, eHealth as Vice President of Monsanto Health Solutions, genomics as President of Cirone Genomics. Boy, I tell you,
come on, you know,
we are talking a heavy
these
resume.
These are all ancient history kind of startup companies and things.
Fair enough.
Young
I adore it. And I'm wondering, did you two meet at Stanford University, or is it just you both went there?
Oh, he's way younger than I am.
Okay, fair enough. Good call. Okay, let's move on to our talk today, folks. Let's take a look at it. Okay, so I'm going to do a quick little intro. I wrote something. I want to do it because I always like to do intros. We are looking at the future of medicine right here today. As you can see from this infographic, there are lots of collaborators working together to design the systems of tomorrow for these durable therapy drugs, which we're going to talk about in a moment. I've always known the prescription drug makers to alleviate or treat symptoms, but unable to provide a cure. We're looking at some cures here, or at least some durable therapies that are close to a cure, which is something really different. We're not just treating the pain, we're actually making people better. The reality is changing because of the advancements in gene therapy and cell therapy. We're closer to cures than we've ever been. So the subject today of the Fireside Chat are these FDA-approved durable therapy drugs that have already changed how medicine is created, prescribed, administered, and paid for. These innovative durable therapies cost a lot of money though. And because of this reality, we're going to get into why they cost money. And we're going to talk about some access issues that happen and the reimbursement industry. We need to prepare, okay? Self-funded, we need to prepare. That's our industry. And so, Mark, give us a quick rundown. What's going on with these therapies? Why are they so expensive? Talk to me a little bit about the collaborations here. And please explain what NEWDIGS is doing today. Welcome, Mark.
Hey, thanks so much for having me. It's wonderful to be with all of you today. Thanks for making time out of your busy schedules. So NEWDIG stands for New Drug Development Paradigms. It's a project that began about 15 years ago at MIT. We recently moved to Tufts Medical Center to be closer to patients and providers. MIT is fantastic in what it does, but it doesn't really participate in the healthcare system in the same way. So we're happy to be over at Tufts Medical Center now, but we brought along our whole consortium with us, where you see many of these different providers and payers, policymakers, regulators, a few researchers like myself, and a bunch of biopharma companies to address these challenges in our Financing of Cures project about what we call durable cell and gene therapies. So these are these new transformative therapies where they actually use genes in viral vectors at times, or transform cells outside the body and insert them into your bone marrow or your body, so that your body now naturally makes the things that you used to have to take a drug for. So for example, the latest hemophilia gene therapy that just got approved in the last month or two, it actually now allows the hemophilia patient to make their own blood clotting factors right in their own body, and they no longer have to take artificial human replacement factor 8 or factor 9 injections anymore when they've had this gene therapy. So it's fantastic for those patients. They're no longer taking drugs. It's fantastic for payers who no longer have to pay for that month after month. The challenge is many of these are both very expensive to manufacture, particularly if they have to harvest the patient's cells and transform them and then infuse them into the patient. Everyone is different. They have to make sure that they don't cross the cells, so there's a lot of paperwork and checking, and the manufacturing doesn't always work, so they have to redo it. So the manufacturing cost for these products is measured not in the pennies or the dollars, but in the hundreds of thousands of dollars oftentimes for each patient's drug. But it's also a change in the paradigm, in that now the drug manufacturer, instead of selling their therapy every month, say, for antibody injections, now only has one billable event, and it's going to now, that therapy will last for 5 years, 7 years, maybe 10, or an entire lifetime. So we've sort of gone from renting the condo to buying the condo, right? And so it's not a surprise that when you have to buy the condo, the amount is more than the monthly rent payment for these things. And that's why they're so expensive, because in essence, they're taking a 3 or a 5 year series of monthly payments and putting it all up front, saying that that's the value of the therapy, that's the value of the condo. And then if it lasts longer than those 3 or 5 years, in essence, you get it for free after that. The challenge is healthcare hasn't had a sense of a mortgage to help anyone pay for that condo up front. So it just looks like, my gosh, it's a gigantic one-time rent. I'd be glad it's only once, but you're going to bankrupt us through this whole thing, where I don't have that kind of money sitting around. And that's where these concepts of precision financing come into play. And in fact, if we could go to the next slide, just really briefly, that shows this sort of one-time high cost thing is one of the 3 financial challenges that really come into this. But Gray, did you want to follow up with some questions, dig a little deeper into this, how many products are coming or why they cost so much?
Well,
Yeah, I definitely want to get into that. And I do want Dr. Paz to jump in, but I just want to follow up with Mark with what you said. From the reading that I've done and the research that I've done, these drugs, therapies are extremely expensive. And I love how you bring up this condo, right? The way drugs are traditionally paid for, and if costs get too high, stop loss pops in. That's going to have to change. That's what I hear you saying, Mark, is that there's got to be a sort of a different system, and that's the precision financing. Is that correct?
Well, it is. And for those of you who have stop loss at the moment, the number of these products is pretty small.
Okay.
And they're usually for very rare conditions. So the stop loss premiums have not skyrocketed yet through the onslaught of these. But as everyone who's noticed lately, I think stop loss premiums are going up even more than the current CPI, right, which is dramatically higher over the last year. And that as more of these therapies come forward, we expect there could be this rising tide, and that since many of them will trigger stop loss, those stop loss premiums may indeed accelerate over the next few years. So it's not a crisis in the next 12 months, but it's increasingly getting worrisome. It's somewhere between a hurricane and climate change, right?
Okay.
You're not quite sure how quickly, but you know that there's going to be this surge of cost coming up. And we think that we can adapt to it, but there's a number of options to address it. Ron, you wanted to get a word in, I think.
Yeah, I'm curious, Mark. I was invited to join NEWDIGS, what was it, 6 years ago or so?
I think so, yeah.
Pre-approval, final approval for the CAR T therapies. And we were thinking then that was going to destroy the whole system. CAR Ts became available and they were so costly, $500,000, something like that.
Sorry, what are CAR T drugs, please?
So CAR Ts are cells that are manipulated from the person's own body for now. Cells that are created to fight the blood cancers. So they're produced, modified, and given back to the patient, which then fights the cancer. And they work pretty well, but not for everybody. So as we were looking at that, Mark, can you see the difference between how we sort of thought about that then and how we think about it now?
Fantastic. So, Ron, as you know, when we began this, if you looked at all the venture capital hype about how many products were coming, they thought this was going to be a $500 billion new drug segment, $500 billion a year, and that there were going to be hundreds of these new therapies coming forward, and it was going to happen in 7 to 10 years. And you can imagine that scared everybody a lot on the payer side. Right? Great news for patients. We're all going to get cured of all these things, but my gosh, how could we pay for this? So we actually did some detailed modeling of all the clinical trials in this space, and we applied what were their success rates to date, right? Because not all drugs succeed through the clinical the development process, and we matched it up to how many patients actually would qualify and be eligible, because beyond just having the condition, there's usually some other biological or other constraints. You sometimes can't give it to children. You sometimes can't have other sort of biological characteristics that exclude you. from having these therapies. And we came back with numbers that weren't in the hundreds of billions of dollars, but in the tens of billions of dollars. And tens of billions is a lot of money, but there's no doubt, right? But in the total drug spend, like the whole specialty drug spend today in the United States is probably around $300 billion. The total drug spend is about $600 to $700 billion in the United States. So 30 billion or $40 billion, and we think it's closer to 25, but 30 billion is an awful lot of money, but it's still like a 10% rise, which looks like it could be manageable. And then many of these therapies, like the hemophilia one I just mentioned, the CAR-Ts that Ron just talked about, they may replace existing therapies. So it's not all incremental money. There's some offset through all this. And when we did our forecasting, we were thinking in terms of list prices. And of course, you guys all get discounts and you have people who really work on that, like 6 Degrees Health and others to keep those costs lower. So it appeared to be manageable, and yet these are special. And, you know, if it's $2 million for your firm in July, that's still a CFO reportable event, and stop loss, yes, is going to kick in, but, you know, there could be, who knows, when there's that much money, people sometimes look at fine print and see whether they're really eligible or not eligible for these things. Hemophilia is going to be a particular challenge with stop loss on whether the patient got lasered out, right, and doesn't apply, and therefore this what's looking to be a $3 to $4 million hemophilia gene therapy treatment, that patient may have been a $500,000 a year patient, but $3 million is a big difference from $500,000 a year that you may have grandfathered in. But if stop loss excluded the whole patient, then they may not cover the new gene therapy through all this, right? If they didn't exclude the drug treatment as opposed to the person. And so you got to read the fine print on these contracts, and that could be really somewhat catastrophic, right, for many of the people who are here or the clients of the various brokers. This is where we think there are other models that either augment stop loss, or that stop loss, really you need to have an awareness of these products as you look at the policies to make sure that saving a little bit on premium doesn't actually cost you if all of a sudden you have a $2 million baby show up, that it's really covered. Because some of the stop loss policies, we are told, we haven't seen all the details, those are all confidential, we've heard rumors that some of the stop loss policies may be excluding cell and gene therapies, just blanket exclusions that we just don't cover them. And we've heard that some employers are also choosing under the ERISA rules that they can also decide what they cover or don't cover, and are also excluding these. But that can, of course, put then your families and your employees in very difficult situations going forward. So there are different ways to approach this that we think are affordable for everyone. It starts with having a good stop loss policy that will cover these things. But then within that, seeing through and making sure, for example, that if there's a performance risk contract being done by someone you've contracted to, that you as the employer might participate in some of the savings if the performance doesn't work out as well, that you get some of that performance rebate back. And I can talk about that more in a minute. You want to stop there? I can talk a little bit about the pipeline and how many products are coming.
Let's do that. I just like the audience to know that these kinds of conversations that and the issues that Mark just raised are the kinds of conversations and searches for solutions that we at NEWDIGS have been working on. We do it in small groups, we do it in online groups, we get together a few times a year. It's really, I just have to let you know, it's a tremendously exciting opportunity, and Mark does this fantastic job of facilitating that, bringing information like you're hearing today. Just a plug for the NEWDIGS work.
Yeah, well, I do want to jump in real quick, Mark, on the previous slide at the bottom. If we can go back one slide, please. I do. Perfect. You've got these 5 precision financing solutions. You were kind of leaning on them, talking about them a little bit. And I look at these and, for example, the subscription sort of Netflix model, like, do you want to speak on that just a little bit before we pop over to the next part of the discussion?
Yeah, I'd love to have the opportunity, but to give people a sense, I hinted we weren't going to have hundreds of these, but we are going to have a couple dozen of these in the next 2 to 3 years, most likely. And by 2030, we're expecting about 70 of these to come forward. So it's more than just a handful. And across the bottom on the left-hand side, you see somewhat that blue bar at the very bottom saying outcomes-based design in little print, if you can read it. And this is because we don't quite yet know how long these cures, if you will, are going to last. We have clinical evidence from the trials that they're going to last three years, maybe 4. In the CAR T cancer space, they're now up to real world evidence of 5 to 7 years, I think, Dr. Potts.
Right.
So we're getting a little more confident there. But like this new hemophilia drug came out, we've got like 3 years experience. Is it going to last them a lifetime? Or is it going to peter out after 4 years or 5? We just don't quite know yet. So these outcomes-based contracts are what many of the larger payers are putting in place with the drug companies. All right. Now, they often don't share the details of those with the self-insured employers. So this transparency issue is something you may want to talk to your third-party administrators about, that if they have one of these multi-year performance-based annuities or a milestone contract where if the patient doesn't do well after a year, you get most of the money back, you may want to make sure that you as a self-insured employer are participating in that rebate that comes back from the drug manufacturer, that it really flows through directly to you, because these are not things that all sort of wash out in the averages across everything. This isn't like blood pressure medicines, right, where many of your employees across all the different employers generally have them. These are very specific, targeted, high cost and rare therapies that only a few of you are going to experience. And therefore, if there's a rebate associated with that, only a few of you should really, I think, maybe want to benefit from that and see that come back to help pay for those stop loss deductibles and other sorts of things that you'd have to have paid for these. So those 3 flavors are basically a short-term version, a long-term, many-year version, 3-5 year sorts of version is that multi-year one. Then the warranty model is one where you don't get a rebate on the drug per se, you get a rebate on, they pay for the other therapies you'd have to take. So let's pick on hemophilia, since I've been on it a lot. You heard me say that today they have to take factor 8 or factor 9 replacement through an injection. And so the warranty would say, we don't give you money back directly on the drug, we'll pay for all the extra factor that the patient has to use over some period of time. And that way it sort of retitrates automatically for how much that patient needed. Did the drug perform, did the gene therapy do terribly and not work at all, in which case they pay out a lot on the warranty? Did it mostly work and just little? So it's fair in that sense that it automatically sort of titrates to how well did it not work. But again, with your third-party administrators, you're going to have to see, well, how does that warranty play out then back to your own costs that you're seeing coming through? The other 2 sides, the subscription model and the orphan reinsurer and benefit manager, those both are in this sort of pooling category, where for a fixed premium, say per member per month or per member per year, you essentially get access to all or most of the gene therapy that your population might need. And if you don't have a case that year, well, it's sort of like buying car insurance and you don't have a wreck, right? You sort of paid into it. But if you should have not just one, but say 2 or 3, you got one of these babies that needed a treatment, you had a hemophilia patient that you hired that was new to you, et cetera. They just guarantee you get all the gene therapy that you need for that, call it a year, through all that. And so it's complementary to the stop loss. And I think this is a real opportunity to mix and match these products. So your stop loss may have lasered out the hemophilia patients, but one of these models, the subscription or Netflix models, most of the large insurers now are offering them as sort of separate products. You know, Evernorth has one, Blue Cross Blue Shield, CVS is offering these. And so you can mix and match the features of your stop loss product with these sort of subscription model tools to really make sure that you're covered in the most cost-effective way possible. You don't want to buy double coverage, but you also, if the stop loss people are lasering out your patients, you may want to cover yourself on some of these. Ron, do you have more comments on that? Did I do an okay job?
Certainly, of course
Great.
you did. I will comment on the ORBM and all these models, particularly the ones that are longer term. We have to keep track of how the patient's doing in order to make them work. And, you know, in our so-called healthcare system, people change insurers, and thus the information about that particular patient doesn't necessarily travel along with them. And I remember the day that we first heard about the ORBM kind of approach as one way to manage the information flow for the rebate or some of these reimbursement models.
Awesome. Let's move on to the next slide and get into this piece here, Mark. In 2018. Okay, go ahead. Yep.
Yeah, so this is really pretty simple, right? In that payers, as the headline says here, they really only want to pay for drugs that work. In fact, I think there's a question in the chat that sort of hints at this. How could you take on this liability if they don't work for everybody? And that's exactly what most of the payers in our consortium said. And what they really said that they most wanted to say is on that far right side, that they only wanted to pay for the therapy when and if it works, and that the sort of price surge for many of the even mid-sized insurers who might have reinsurance, et cetera, was less of an issue than this justice issue, right? This issue of, if I'm going to pay a couple $1 million, it really ought to work, right? If I'm using other sorts of drugs and it only gives partial response, like say many of the autoimmune disorder therapies like the anti-TNFs, they work really well for some and not so well for others. But those, you know, you try them for a little bit, and if it doesn't work, you move on to something else, and it's a little bit of wasted money, but it's not the same thing as this one-time really expensive fee. And so we're seeing more and more, particularly in the cell and gene therapy space, it's almost it's not quite the usual way, but it's almost a common way now that you see some form of an outcomes guarantee on these products coming forward. The flavors and the amounts all sort of match, and it's the free market system at work. Everybody's trying to figure out exactly where the right point is, but it's becoming really common. And it's because payers and people like you on this call are basically telling the drug manufacturers, this isn't like blood pressure meds again, where we treat a lot of people and we know that some people are going to do okay and it's all kind of works out in the end. These are just too expensive and too specific. We really need to see that it works, and we want you to stand behind that. Ron, is that your sense of what's going on in the market?
Very definitely. So, go ahead. No,
I was just going to say I was interested in your views and Gray's view, as since it's supposed to be a chat both ways.
Well, I was just going to jump in.
As to whether you see the transparency between sort of the large PBMs and others in the middle back to this community, that they're being transparent about these things. Is that happening too? Because I don't see that as much.
That's a great question. What do you think, Dr. Potts?
Yeah, I think the transparency is not there. I think that the difficulty of wrapping heads around this and how to think about it is still there. I think the opportunities need to be presented. It's an area that folks like Mark, who know this field so well, really need to be able to have the audiences to begin to have the thinking that needs to go on about how these things could work and how the transparencies should evolve.
Major shifts in thinking. Yeah, absolutely.
Major things.
Yeah,
Major
and
shifts.
it's also
That's really right.
yeah, and in fairness to the TPAs, it's major shifts in their systems,
And-
right?
right.
Because
Yeah.
their standard, hit the button and give you the report system doesn't call out drug by drug rebates, right? And here you're asking them to call out a particular high cost set of drugs to be transparent about. And that's just not what they normally do. They're not set up that way. So a little empathy, right? But that's why smart computer scientists get paid a lot of money by these guys, right? Just to be able to do that.
I do see some questions coming in. I think we've got a couple more slides to go over, folks, before we get to some of your questions. So let's go through this, Mark.
Oh, this is an eye chart, and most of you, I'm going to ask you to go to the resources on the next slide. But this says we've identified a number of players in the marketplace who, beyond doing the reinsurance and stop loss sorts of things, can help you negotiate these contracts directly. If you're a larger employer, companies are known to be happy to write contracts directly with large companies, large self-insured employers. There are companies like 6 Degrees Health and others who help with the provider contract negotiations and making sure that patients get to the centers of excellence for this. And then for some of these versions like the warranty models, you may find that you're dealing with yet another kind of company. You may be talking to AIG warranty services as opposed to strict CVS, because now the drug manufacturers is putting in a classic car warranty kind of approach, and they have to go to the car warranty kind of companies to administer these things. So Pfizer, for example, is working with AIG, right, to do this, which is, who would have thought that combo was ever going to be here? And the challenge is you now have to fill out the AIG paperwork to get your money back on these things, right? So it's either value add for the brokers or just another, oh my gosh, another set of forms to navigate within the healthcare system.
And also, Mark, I might point out that for some of the very large payers, the opportunity to direct contract with the manufacturers has been offered.
Yes.
And can apply to their covered population.
Right. And what the eye chart on the left, it's a beautiful table if you could ever read it, but you see the dots all over the place. It shows that the marketplace hasn't settled down. Whatever sort of combo you want, there's probably somebody offering that kind of a combo. That it's not like solid lines or solid columns worth of stuff. It's all sort of over the map right now. And I'm sure it'll settle down in 3 or 5 years, but at the moment, there's just a lot of experimentation going on. So it's the great time for you to vote with your actions as to which one of these models seems to work best for your situation. And then the final slide is just a little plug for all those things you couldn't read on these slides. And if you want projections, et cetera, go to our website, the Paying for Cures website, where we have snippets of talks like this. We have spreadsheets that can help you run the numbers for your particular population or particular product. We've got lots of, we call short research briefs and longer white papers to help you learn and understand about all of this.
And folks, all these resources, we'll send out a link at the end. You'll get an email from 6 Degrees Health recapping our show, also an access to our recording on our website. So look to that in the next couple of days. I do want to get to some of these questions. Heath Potter, I saw them coming in. Certainly that first question that came in, we talked about it a little bit, but when it comes to things like fiduciary responsibility and how our plan is going to pay for this, what are some of the other questions that are popping up?
Yeah, looks like some of the questions are coming in the chat function, so it makes it a lot easier on me, guys, if you use the Q&A function on additional questions that come in. But we will, let me dig back through the chat here. It looks like one came in. When you talk to some of these therapies, you cannot guarantee a true cure. How can an employer and their stop loss carrier be willing to take on this type of liability for the plan from a fiduciary standpoint?
So most medicines don't work, right? So this is just sort of across all drugs. We have about a 20 to 40% effectiveness rate. So the fact that most of these gene therapies and the CAR Ts are in the 60 to 90% rate, they're actually better than most for this. So from that sense, compared to all the drugs we pay for that aren't working today, these are actually a little bit better. From a fiduciary standpoint, if they're a classic plan, these are medically necessary and therefore fall under the medically necessary treatment rules, and they have to be covered. If you're a self-insured employer plan under the ERISA rule, you get to set your own rules as to whether you want to cover these or not, right? We believe with stop loss and some of the other problems, it can be very affordable to you and be something you can be proud of, that you're supporting your employees and their families, and that it's something that people know if they come work for you, they're going to have coverage if these terrible things happen to them and they need them. But that is your call if you don't want to cover them. But I hope I've inspired you that it's not a huge deal immediately. It's not going to bankrupt the system over the next period. It's rather just one more of those costs that you can manage and manage well. And with some cleverness, get a pretty good deal on going forward.
And I think I just add to that, Mark, there is a huge need with these higher cost therapies that work very well for some and not for others, even though they may look alike, they may have same characteristics, the patients, that is. That the work in defining the patients who will be responding to these therapies is very important. And there is a tremendous amount of work going on, not only in the gene molecular biomarker field, but also other very interesting kinds of characteristics on the patient side that will help target these in a more precise way, these therapies. I think the whole healthcare community needs to be really pushing for that kind of knowledge. And we absolutely are working with that at NEWDIGS in development of real world evidence platforms.
Yeah, and I think it's a huge opportunity for the self-insured employer marketplace to, with one voice, say that all your claims and cost data you want, along with medical records to which you have legal access, to be part of a broader understanding of real world evidence of where these things work and don't work. That's a real opportunity where, frankly, many of your third-party administrators may or may not have the same incentives that you do to really learn about these things. They should, but economically, it's not clear that they do, and that this would be a place where, again, your ability to push on transparency and sharing learning amongst all of you about what's working and what's not could really move not just your cost position better and serve your employees better, but actually move the entire field of medicine forward in a more powerful way.
All right, thank you guys. Okay, if your TPA or carrier is not offering this type of precision coverage, who is the employer buying this from? When, for example, the stop loss carrier has lasered a hemophiliac?
So, Ron, do you want to answer that? You're close to it. I can rattle off.
Yeah. Why don't you rattle off?
So the short answer is that nearly all the large TPA carriers are now offering a gene therapy subscription model, right? At least I know that Evernorth, formerly known as Cigna, is doing so. The Blues have a plan that's out. CVS, Aetna has a plan that's out, and I believe Humana has talked about it. I'm not sure that they've rolled it out, but essentially at least the big 3 or 4, I believe United has a plan that they haven't made a big splash about, but is available if you know to ask for it. That these plans are all there. You would hope that your TPA would offer it to you. If they don't, you could or should be able to shop it from others. In any case, we have heard that some of the big firms are just in the fine print charging you for it anyway. and then they buy stop loss, and you might be buying double coverage. So there is a need for benefits coordination here, and they should have separate pricing for these as well. And sometimes they just sort of blend it into an offering, and you may be able to price shop amongst these subscription models. And that's not always apparent, I'm told, that you get sort of a bid from the TPA in which this coverage is simply embedded in the fine print. At times we've heard that happening. So as always, being an informed and a smart buyer to unbundle things can be helpful, and you should be able to price shop.
Yeah, I was going to jump in and say, read the fine print. Absolutely. Heath, I know we've got a couple more questions coming in. I've got a question. Maybe I can pose that first, if that's okay.
I don't know. I don't think I want to keep Jackie's question waiting here. So let's get
Okay,
hers
Jackie,
done,
let's
and
do
I'll-
it.
I'll pass it over to you. Yeah, she's
Okay.
I've known her a long time. So let's make sure this happens. What is your feeling about the FDA not requiring REMS or REMS for REMS? Oh, she's messing with me now. Hemogenics and the criteria requirements from the clinical trial for administration on the package label.
Well, so
Well,
Hemogenics is this new hemophilia one. Jackie, it's great to see you. You know,
Jackie.
on this, it's always great to have you part of this. So, you know, my feeling is that the FDA is going to require what the FDA requires from a payer standpoint. Payers need to require what the payers are going to require, right? And that relying on the FDA to follow these things or not is always a bit of a challenge. So the REMS historically for cell and gene therapies, the guidance was originally to cover for 15 years, every patient that took one of these new cell and gene therapies was supposed to be followed. The final guidance came out, followed only for safety, not for efficacy, not for whether it worked. The original guidance, the draft guidance, had said they were to be followed for both efficacy and safety over 15 years. That got dropped. It was never explained why it got dropped. To be clear, in general, the FDA never tracks efficacy post-approval. They only track safety post-approval, right? So they have big formal systems called pharmacovigilance for tracking adverse events, because short-term trials, you often don't pick up long-term safety problems, right? So that was the original rationale. But the FDA hardly ever tracks efficacy. There is no efficacy reporting systems. The only way you get more efficacy data officially is either through a REMS requirement, where they're concerned about this, but also through accelerated approval. There's a need to have a further confirmatory trial. But this was not a surrogate endpoint. Hemogenics used a real sort of solid clinical endpoint. And FDA chose not to require efficacy in the REMS.
Mark, for part of this, don't you think that with the common platform for some of these drugs that is now fairly well proven, that some of this REMS will not be happening, some of the work, like
so
for their CAR T stuff?
Certainly in the CAR Ts, where people are getting better at managing all the side effects from CAR Ts, I think there's, we believe that we understand them more. There seems to be less urgency to follow them. But each one of the new products coming out is also making a claim that they're safer.
Yeah.
Oftentimes. And so I think the FDA, I hope, will continue to be interested to see whether those assertions of higher safety really play out in a larger real world population as opposed to a small clinical trial population. On the gene therapy side, where it's often these AAV therapies where you basically infuse somebody over what looks like an IV bag, most expensive IV bag in the world, going into them, that carries all these viral vectors that then carry the gene to the right place. There, I think we're getting, again, now 5-7 years of sort of safety experience with that. And my sense is we're getting more comfortable over time. There haven't
Well,
been a lot of
particularly-
challenges.
Particularly with the companion diagnostics that go with some of those.
Mhm. And Dr. Potts, I'll defer to you on the clinical trial administration package label stuff. I must admit, I'm not a physician and I'm not sure. I'm in over my head as a
I
health
actually-
economist on that.
Jackie, I actually haven't read that clinical trial on the administration piece, but maybe I should. I'll take a look at that.
Great questions. Thank you, Jackie. I'm going to ask one unless Heath interrupts me. Something that I learned about when we were talking, Mark, when you were giving a previous panel, is, the idea is that people come and go from jobs, right? They might step into a job, be there for a couple of years, of course, then move on. So how do we, as a self-funded insurance industry, or how do people manage these patients that move from plan to plan? I want to hear your thoughts about the patient mobility issues that are sure to pop up.
Yeah, so there's a couple ways to view this, which is one, that it's incredibly unjust that you might have to, in essence, buy the very expensive therapy and then that employee moves on in a year, right? And you basically bought them a therapy that was supposed to last for 5 years or a lifetime. And, you really helped out the next employer, but you yourself, grossly overpaid for the benefits that you received. So if that's the way you feel, one of these umbrella sorts of policies where you pay for an annual PMPM and you get all the gene therapy that you need in that period addresses that to some extent, because you're only paying your small amount, sort of your average risk, and then every year you pay for what your average risk is for having one of these therapies come forward. And so that really converts again this one uptime high cost payment into a whole series of annual lower cost PM sorts of payments over time. So that mechanism really does address that. As does stop loss insurance, if stop loss is covering these for you, right? That's the same theory around stop loss in insurance. For those of you who choose to contract directly or have some of the rebates come back, I think that's your perspective, that you're willing to take that risk to get a little more engaged with the delivery and management of these products. And if they don't work, really make sure that you get a good rebate back from all that, and not in essence overpay for them through this sort of washout sort of an insurance process where everybody's taking a little bit of a cut because you have to run an insurance thing, right? So as often, if you do direct contract, you have the opportunity for lower costs, but you're going to get the volatility that goes along with that. So you'll have to pick your poison, so to speak, as to what makes the most sense for your firm. And if you're a giant self-insured employer with hundreds of thousands of employees, you're basically running an insurance plan anyway. So therefore, you probably want to do it directly.
Great perspective.
All right, I got a question over here. Yeah, we got another one on the Q&A panel here. Since the FDA has approved some initial therapies, how has Medicare priced these? Since for most self-funded health plan, Medicare is one of the data points used for pricing.
So the CAR T therapies were really included in DRGs. And there was a huge challenge that Medicare patients were not being reimbursed sufficiently to cover the drug. They had a special thing called a TAP charge, sort of an over and above. It was set, many of the hospitals thought, way too low for what the costs of both the drug and the care was for these. That seems to have resolved, but the prices came into about now $300,000 to $400,000 seems to be where Medicare is coming out on the CAR T. So when these happen on the commercial population, you're getting some visibility into that now. And the group called ICER, which does sort of the cost effectiveness analysis of these CAR Ts, has nearly universally come out saying that these CAR T therapies are indeed quite cost effective and actually in many of the cases save money compared to the alternative kinds of cancer treatments that patients are getting today, right? So in that case, it seems to be a wash. And in fact, the CAR T, if you think your employee is going to stay with you for a few years, so you get that 3-year benefit from them, they're no more expensive after 3 years than if they just stayed with you and did classic chemotherapy and precision medicine and all the other oncology stuff. And then, of course, if it's one of these pediatric, only happen for babies, well, they don't qualify for Medicare, so Medicare isn't relevant to those products. Medicaid is very relevant to those, but not Medicare. And the Medicaid prices are set off of the commercial prices, so there's really not much help back and forth between those markets.
Excellent. We've got about 8 minutes left. I definitely want to get the outro in. Heath, do we have any more questions for Mark and Dr. Potts?
Jackie threw a comment in here. I don't know, Ron, if you can see that in the
Yeah, I did. I'm responding
in the
to it.
chat.
Yeah. What Jackie's put in there is that there was an attempt to make sure that the clinical trial information on the various antibodies that were excluded, the patients were excluded from the trial if they had that, then didn't end up on the label. So back to my comment earlier, we need to know which patients are going to respond, not respond, or have major adverse effects from if they carry some of these antibodies, for example. So it seems to me like it might have been a good idea to place this warning on the label, particularly if there's not a companion diagnostic that goes with it. And that's about as far as I can go on this, Mark, unless you know some more about that information.
No, I don't, except for those of you who don't know biology acronyms, the AAV acronym, for example, that's the viral the vector, which is moving the gene into the person's body through this. And if you have antibodies against that virus, because you had some kind of a cold that was an AAV cold, and therefore you have antibodies against this, the concern is that the new gene therapy will never take, it will never get to your organs, because your great immune system will wipe it out before it has a chance to get in and do the good stuff that we want it to do. So your body, thinking that it's bad, will clean it out. And so you just spent $2 million for your employee's immune system to wash it out with their urine, right, through all this. So that's the concern, apparently, for this therapy. The FDA was not concerned that that was going to happen for these, and chose not to put it on the label or make it some kind of a restriction. I don't know the science behind that particular choice, so I best be quiet. The FDA usually doesn't do things without some rationale, but Jackie apparently, and at the face of it, it would seem
Well, I know
this
at least
is questionable.
Yeah, one of the other hemophiliac coming down to probably be released next year does have the companion diagnostic for detecting AAV reactivity. So
Yeah, but even without the companion diagnostic, I think Jackie's point is you ought to at least know if you excluded them all from the clinical trial, you have no evidence that it works in people with these antibodies.
Yep, right.
It would be nice to let people know that that's at least a risk. I don't know why the FDA chose not to do that.
Thank you for that. That was actually, again, fascinating to learn about how these drug therapies get into the system, and utilizing a virus in order to bring that into the body is my brain just exploded. Again, I learned so much from these. Thank you so much, Dr. Potts and Mark. Let's wrap things up. Heath, shall we wrap things up? Yep. Okay, perfect. Mark Trusheim.
I didn't even get to respond to that. I had a great statement to make, but
oh, bring it. What you got?
No, I just want, it just occurred to me, I think this is our second full year of doing fireside chats. I think we started in December of whatever 2 years ago would have been 20. And it's just really neat to see how these have developed and all the different conversations we've had, and to have Dr. Potts joining us today, who I've worked with for a long time, and see folks in the audience like Jackie, participating and helping drive this conversation, which is why we brought this whole thing together. So I'm just kind of sitting here reflecting, and wanted to say thank you to everybody for being a part of it. So.
Thank
Absolutely.
you, Ethan. Great.
Yeah, I mean, this is Heath's brainchild. He came up with this back in late 2020 as a way to engage. And now that we're all coming back to the office, we still do this because we really like the conversations. This is inspired by a conference that 6 Degrees Health puts on, the Sun River Summit. You can find that on our website. And we sit around a campfire, and we like to talk about engaging, fun, exciting, difficult conversations around self-funded industry. Thank you, Jackie. So this is Mark Trusheim. So glad you showed up from NEWDIGS. He is over at Tufts University, Tufts Medical Center. Same, I'm sure. Thank you, Mark.
You're very welcome. Glad to be with you.
And then we've also
Yeah.
got Dr. Ronald Potts here. Dr. Potts, thank you so much for joining us. I was on a call with Dr. Potts the other day. He had a soccer game going in the background. So it's a good times had by all. Thank you, Dr. Potts.
Thank you. And thank you, Mark, so much for accepting the invitation and delivering your deep knowledge of this to our audience. It's great.
Big time.
It's
Big
great,
time.
great to be with everyone. Thanks for the really fantastic questions.
Oh, yeah. Heath Potter is our Chief Growth Officer here at 6 Degrees Health. 6 Degrees Health, cost containment solutions. We do everything from transplant, specialty. We work with TPAs, brokers. We work with providers. We do direct contracts with providers. We're very well known for our reference-based pricing solution. If you have any questions, feel free to reach out to Heath Potter at 6degreeshealth.com. And next month, we do have an exciting chat coming up, which is reference-based pricing, looking at reference-based pricing plans, strategies for successfully resolving balance bills and provider payment disputes. In 2023, we have our General Counsel, Bonita Hatchett-Bodel, and then our founder, Scott Ray, will be joining us as well from that plan perspective. That is on January 17th, 2023 at 11 a.m. I can't believe 2023 is just around the corner. Please visit our website to learn more from us about our fireside chats. You can watch past episodes. You can reach out to Heath Potter. I am thrilled to be here. I came onto the self-funded industry about 2 years ago, and this educational series has really bumped up my game as a learning and development specialist here at 6 Degrees Health. Thank you all very much, and we'll see you again next time at the Fireside.
Take care, everybody. Thanks for being here.
Thank you. Thanks.
Bye-bye.
Bye, Mark.